My name is Ros, and I'm the mother of Harry, who at 17, almost 7 years ago, had two strokes. Harry presented at school one day with clear, fast, positive symptoms. His face was drooping and he was drooling slightly. He was unable to do up his shoelaces, and his speech was slurred. His father was rung and took him to our GP, who advised us to take him straight to accident and emergency department at our local hospital. He was seen by a relatively junior doctor who did recognise the fast positive signs, but ruled them out as a possible diagnosis because of his age. She consulted with a senior colleague, but unfortunately not with a neurologist or a paediatrician who might well have had a different perspective on the issue, being more experienced with symptoms like this in children. He was sent home with a diagnosis of a migraine. 2 days later, Harry had a major stroke on his way back from school. Again, paramedics arrived and fast positive symptoms were seen immediately. At this point, his face was drooping. He was unable to move his left-hand side at all. His speech was slurred and he was not very coherent. And they immediately made the decision to take him to a hyperacute stroke unit. On this occasion, that decision was overruled by the Central Ambulance Service, who advised to take him to the local accident and emergency department because of his age, although he could have been taken straight to a hyperacute stroke unit. As a consequence of this delay, he was almost 4.5 hours later arriving at a hyperacute stroke unit at this time is brain critical time. As a consequence of that delay, he is left with many much more significant difficulties than he would have had he been transferred straight to a hyperacute stroke unit and had the thrombolysis that he subsequently had. Almost a year later, Harry had a second stroke. This time, he was able to clearly articulate to all of the people around him, paramedics, that he was having a stroke and was transferred immediately to a hyperacute stroke unit, received thrombolysis, and was left with no more difficulties than he'd had from his original stroke. At this point, time was managed very quickly and his brain was preserved. Harry's strokes have had a significant impact on his future life. He has benefited significantly from intensive therapeutic interventions, and even now, 7 years on from his stroke, is still making progress. Children's brains are much more plastic than adults, and the potential for recovery should never be underestimated. Even at this point, 7 years on, he is getting new movement in his fingers and is also recovering in other ways physically, particularly around his shoulder and strength. The biggest impact of Harry's stroke at this point on his life is the psychological and cognitive difficulties that he has been left with. He has difficulties in making and maintaining friendships and making relationships with people within the world of work and in other situations, partly because of his cognitive difficulties and partly because of his confidence as a young adult with disabilities. His life chances in terms of work are severely limited as he has very poor concentration skills and finds it difficult to focus on activities and tasks. And as a consequence, is now working as a carer for a young person with learning disabilities, which he loves, but when his future ahead of him was likely to be as a lawyer or some similar profession.
Hello, I'm Dr Vijeya Ganesan. I'm a Pediatric Neurologist, and today I am going to deliver a learning package around childhood stroke. So the topic of stroke in childhood links with other medical licensing assessment topics in children, such as seizures, cerebral palsy, meningitis, sickle cell, and varicella zoster infection. That's chickenpox infection. You may well be familiar with the acronym FAST, Face, Arm, Speech, Time to Call, which summarizes the commonest feature of stroke in adults. In fact, most children presenting with stroke are also FAST positive. It is important, however, to recognize that babies and young infants with stroke may actually present with diffuse neurological signs, such as encephalopathy or seizures. Children with sickle cell disease are at high risk of stroke, and they may present with so-called soft or non-specific signs that may be difficult to differentiate from other complications of sickle cell disease, such as painful crisis. Considering arterial ischemic stroke in children, half of affected children will have a pre-existing medical condition, such as congenital heart disease. I've already alluded to sickle cell disease, which is the commonest risk factor for childhood stroke worldwide. Antecedent infections are extremely common in children affected by arterial ischemic stroke, both varicella specifically, but also upper respiratory tract infections. The commonest risk factors are non-atheromatous cerebral arteriopathies, so abnormalities of the intracranial or cervical circulation, which affect in excess of 80% of patients. Important differentiators from adults are the non-atheromatous nature of this disease, and also the fact that the disease tends to be intra rather than extracranial. A stroke mimic is a condition other than stroke that clinically is indistinguishable, and these are extremely common in children. So imaging is required to differentiate between stroke and stroke mimics. Magnetic resonance imaging is the ideal in terms of temporal and spatial resolution, but in children this generally requires general anesthesia. CT and CTA are quick to execute and generally provide sufficient information for emergency management. Considering management, the principles of acute treatment are firstly homeostatic support, i.e. supporting the airway, breathing, circulation and conscious level. Recanalization therapies such as thrombolysis or thrombectomy may be considered, but are generally off license in the case of thrombolysis, and generally not very widely available in terms of thrombectomy. Stroke is an emergency indication for exchange transfusion in children with sickle cell disease. Moving on to secondary prevention, this will generally depend on the risk factors for stroke that have been identified. The plasticity of the immature brain means that recovery after stroke is different in children compared with adults. There is a mistaken belief, however, that children have complete capacity to recover. In fact, 2/3 will have some residual impairment, affecting a variety of domains. While motor impairment is perhaps less common than in adults, impairments in higher level function, both cognitive and behavioral, may not in fact be apparent immediately and may actually emerge over time with increasing demands.
My name is Kate Hoyle, and our son had a stroke when he was 15 months old. There was a distinctive droop when I picked him up, put him on the floor. He fell to one side. We went to A&E. Now, we were very lucky. I've spoken to lots of parents since, and this isn't always the experience, but we were very lucky. There was lots of consultation with colleagues, but we had a CT scan, and then they knew what had happened. Now, we were told that he'd had an infarct. I would implore you to watch your language. That meant absolutely nothing to us. Had the doctor said he'd had a stroke, we would have understood. Parents will be in panic, they will be in shock, they won't take in most of what you say, but please be precise with your language, but talk in terms that parents will understand. Now, the good news about him being so young was that he made, in relative terms, a rapid recovery. There was a lot of work that went into that, but he did make a good recovery. The bad news is this is a lifetime. This is a lifetime of requiring NHS services, lots of intervention from lots of different people. There's physio, vitally important that happens quickly, but there's all the unseen things. There's the fatigue, there's the short-term memory, processing issues. That has had a huge impact on education. There's the emotional side. We've had to deal with fears, phobias, enormous emotional outbursts that lasted a long time. All of that has a massive impact on the entire family. Parents, siblings, numerous appointments, not knowing what the future holds. There is so much at stake. So the quicker that diagnosis, the quicker support services can be included, particularly physio at the beginning, the less of a drain there is on the NHS. It's so, so important. The good news is he has made an incredible long-term recovery. He still walks with a limp because his left leg is shorter than the other. His whole left side is affected and is weaker, but he is now just entering third year of history degree at UCL and absolutely loving life. And that is all, I think, thanks to a rapid diagnosis, a scan, and all the incredible intervention and help we've had along the way.
So to conclude, stroke can affect children of any age, most of whom present with fast positive features. Comprehensive clinical guidelines are available from the Royal College of Pediatrics and Child Health on the URL shown on this slide.